I think there's a misconception about what migraine is, and people tend to just think that migraine is a bad headache. So a bad headache or severe headache is migraine, and then a milder headache is just a tension headache is the common misconception. But migraine, now what we know about migraine, it's a brain disease. It's considered a neurologic disease.
Podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The affirmation does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello, and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derek Davis, a physician subspecializing in pain management. In this episode, we speak about pediatric headaches with Dr. Jasmine Forte. Dr. Forte is a board-certified pediatric neurologist who graduated with honors from Meharry Medical College in Nashville, Tennessee, and subsequently completed her residency in pediatric neurology at Emory University, where she also served as chief resident. She was amazing to interview and had exceptional answers to all my questions, whether they were relevant or not. I don't have a child, but if I did, I would definitely take them to see her for any headache concerns. Pediatrics is a fascinating yet often daunting field. Many practitioners tend to avoid it altogether if they themselves are not a pediatrician or have some sort of subspecialty training in it. It's understandable. Why delve into topics you think you may never encounter? However, our discussion today sheds light on how understanding pediatric headaches can significantly enrich our perspectives on adult pain management. Whether you're a medical professional or simply curious about the complexities of pain, this episode promises to offer valuable insights. As always, thank you so much for watching or listening, and I hope you enjoyed this episode and learned something. Dr. Forte, thank you so much for being on the show. Welcome to World of Pain MD.
Thank you for having me.
Of course. So how did you get involved in pediatric headaches and I guess in general pediatric neurology?
My journey definitely evolved. And when I went into medical school, I thought I was going to do general pediatrics. Mm-hmm. And so at some point during my clinical years in medical school, I realized I really enjoyed neurology. I enjoyed kind of the localization of lesions and realizing, oh, this person is presenting with this exam and I can pinpoint where it is in their brain before we get imaging. And I thought that was really cool. But I still didn't really like adult medicine very much. And so I investigated pediatric neurology from there, loved it, realized that was the perfect fit, and did residency in child neurology. And then during my child neurology residency, right from the beginning of doing the neurology years, the patients with migraine and different headache disorders, I really just related a lot to them, had a lot of empathy for what they were going through, and wanted to be involved with seeing how I could make their lives better. That's kind of how it started.
Was there a specific mentor you had in residency or prior to residency, maybe in medical school too, that you were like, oh, like I really kind of like this person, like what they do and everything like that?
Interestingly, when I came here, there was no headache specialist at all. And that's what piqued my interest, seeing the need for one. And my program director at the time was very wonderful in finding me resources to look more into the specialty. And I think it was the first or second cohort that the American Headache Society put on a resident education program geared towards, trying to get neurology residents interested in headaches.
Okay.
And it happened at UCLA in 2018. And I went to that and met a bunch of people in the headache world, both adult and pediatrics. Loved it. I was like, these are my people. I found my people. I found my specialty. Was ready to go from there.
That's awesome.
Yeah.
Nice. So what do you think the main differences are in treating pediatric headaches versus the adult population?
I think you have an advantage when you're starting off with pediatric headache. Most adults with headache disorders were kids with headache disorders at some point. And so you're getting to start at an earlier age with getting them treatments, getting them relief, and preventing a lot of the disability that can come with it. The unique challenges typically involve disability related to missed days of school and not being able to participate in sports and make friends and things like that. And then all of the things that can come with that carry on into adulthood. So I like that seeing them as children, you have a chance to really mitigate a lot of the disability that could come in the future.
That makes plenty of sense. That's interesting. Yeah. Are there common types of pediatric headaches you treat or see? And do you feel like there's overlap in adult headaches? And I know you subspecialize in pediatrics. So.
Yes, the vast majority of what I see is going to be migraine. And probably after that is going to be post-traumatic headaches related to concussion. And so that's my main area of practice is both headache and concussion.
Got it.
In general, with pediatric headaches, you'll probably see more tension-type headaches, but most of those are not coming to a neurologist. So I would say for sure migraine and post-traumatic headache is going to be the majority of what I see.
Are there any special considerations for treating and diagnosing headaches, I guess, in general, and then specific to the pediatric population?
Absolutely. So with kids, you're going to be looking out for those red flags to make sure that what you're dealing with is truly a primary headache disorder. So you're going to be looking out for anything that makes you a little suspicious is maybe this is not migraine, maybe this is not concussion related, kind of those scary things that even parents are worried about and why they're coming. Number one thing that most parents are worried about when their child is coming in with headaches is, does my kid have a brain tumor? And so you're doing all the red flag screening. So asking about triggers for their headaches, you're asking about kind of the progression over time. Is it more of just episodes of headache and then you're normal in between, or has this been a progression of symptoms and looking out for the other neurologic symptoms that could be involved and deciding, do we need imaging or taking your treatment from there?
Got it. You most commonly see migraines. Are there other types of headaches you commonly see in the clinic setting?
Aside from migraine, we do see some of the more rare headache phenotypes. So like in adults, you see more cluster headache. It's rare in children, but we see it. We also see some of the other, what we call TACs, so trigeminal autonomic cephalgia. So those are those headaches that occur with autonomic symptoms, red eyes, tearing, severe sharp pain in the face, trigeminal neuralgia being a common one, but there are many other types on that spectrum as well.
Got it. Are there common presenting symptoms in kids, and do you think they differ from the adult population?
There's a lot of similarity in the symptoms, but how they're relayed to you is going to be different because kids don't always have the words to say, I feel nauseous, or the lights bother me, or the sound is bothering me. So you and kids have to infer a lot more from their behavior. So I might ask a parent, well, what do they do when their headaches start? What do they do? And they'll usually say, they'll stop playing, they'll kind of go into their room, they'll tell all their siblings to be quiet. They'll kind of want all the lights off, but they won't necessarily have the words, oh, the lights and sounds bother me like an adult would. If they're vomiting, that's easy. You can see that they're nauseous and having vomiting, but sometimes that in kids will just present as they didn't want their lunch, they didn't want their dinner, they weren't eating as much, just kind of laying around. So a lot more inference from what their behavior is like.
Got it. When someone refers a headache patient to you, is there a common theme you see from maybe like your primary pediatric colleagues that refer them to you? Do you see a theme from the referral source and then also what the parents are saying? Or I'm sure it's a case-by-case basis, but is there a common sort of theme you see from referring providers?
The biggest reason I notice, one of the most common reasons is that, okay, they've been having headaches for a while, and what makes them want to come see neurology is that they're missing school because of their headaches, or they're missing their sports. So it's having a significant impact on their life now, and they really want to get to the bottom of it.
Got it. Okay. And how do you, and you kind of already mentioned this in many ways, but how do you differentiate? How do you do your workup when you see kids and try to delineate what type of headache it is?
Yes, absolutely. So one common misconception is that you need like a blood test or an MRI before you can diagnose someone with a primary headache disorder. But really, it's just a clinical diagnosis. And so we have like what we call like our headache Bible. It's just the International Classification of Headache Disorders. And you can find that online for free. You can look through that. I'll even look at it sometimes in the room if there's a patient who I'm not quite sure which primary headache disorder fits best, and I'll make sure they meet all of the criteria there. And it goes through the primary and the secondary causes of headache, so it's pretty comprehensive. So you'll look through that and make sure you're not missing anything.
Got it. Okay. are there external factors like just environmental and lifestyle factors, like what the kid's eating, how much they've drank in terms of like water or milk? Are they stressed that contribute or mitigate headaches, and I guess more specifically migraine?
Yes, I think those factors play a big role in all types of headache disorders, to be quite honest. And so big things that we harp on, which we call our lifestyle factors, that we ask patients to look at and kind of modify. One is sleep is a huge one, making sure they're getting enough sleep. I find that in younger kids, like elementary school, early middle school ages, that parents are usually on top of making sure the kids are getting enough sleep. Once you hit those teen years and you have the devices in the room and the TVs, and parents aren't necessarily like, you have to go to bed. It's kind of, they're more independent. They're losing more sleep. So sleep deprivation starts to become a concern. We also screen for sleep apnea because poor quality of sleep can contribute to increased frequency of headaches as well. And so if there's someone who's a big time snorer, and in kids, they don't always snore if they have sleep apnea. But if they just report waking up a lot in the middle of the night, is something we screen for, as treating that can help decrease headache frequency. So sleep is huge. Making sure they're eating healthy, but also eating regularly timed meals. For some people with headache disorders, prolonged periods of fasting will trigger their headaches. And a lot of kids don't eat breakfast because they're running out the door. They don't eat their lunch at school because they don't like the lunch at school, or they're just more interested in like socializing during the day, which is fair.
Yeah, that's fair. I mean, sometimes I had pizza when I was a kid.
Yeah, exactly. So by the time they get home, they're like, oh, I haven't eaten all day. I have a terrible splitting headache, and now I'm nauseous and I still don't want to eat. And then it could just spiral from there. So we talk about timing of eating and what you're eating. And water intake, so making sure that they're staying really well hydrated, especially if they're athletes, is really important. Managing their stress and staying physically active.
Got it. Do you see an impact of devices like you had mentioned, like cell phones, and what ways do you see that affecting your patients?
Big time. The number one way is that they're using them at night. All night, and it can keep them up. By the time you're done, you're like, oh, it's 3 a.m. I got to get up in 3 hours for school. Yeah. And so they're just not getting the hours. And then just the prolonged exposure to the lighting in general, we know can impact your brain's ability to secrete melatonin. Okay. And so over time, that's not great for sleep hygiene.
Right. Okay. And do you see any like tension headaches related to perhaps posture?
Yes.
Or anything?
Posture is a big one. When I see that in clinic, sometimes I'll have the parents come over and feel how many knots are just in their child's trap muscles and kind of the poor posture that you get hunched over from looking at your device. So we do talk about, you're going to look at your device, bring it up to eye level, proper ways to do that. For some children, I'll refer them to physical therapy just for stretching and core strengthening to help improve posture, and that can make a big difference.
Man, there's a lot of overlap with adults. I didn't suspect that. I didn't think about that, but it's true. Even with you mentioning sleep apnea, it wouldn't be something I'd think about in kids, but yeah, I'm sure it is a big impact on them. Speaking of impact, how do headaches impact quality of life? And I know you mentioned missing school, missing big sporting events probably as well, but what are some of the other ways that you see the headaches impacting your patient's quality of life?
In addition to, I'd say, obviously school, and that carries on beyond missing a lot of days of school, not being able to participate in sports, long-term impacts their ability to be prepared for college, take their exams, get scholarships. And so it can have a huge impact. And the stress related to it, when it comes to taking SATs and things like that, I really will harp on making sure they get all the accommodations that they need for school to help with that. And so every time I meet a patient for the first time, I make sure that they will have accommodations in place for school. I'll give them a letter and have them set up. What's a 504 plan is what we call it here. So it's for medical accommodation. So it can give you simple things like extra time on tests and assignments, It can give you access, believe it or not, to just having a water bottle with you all the time and bathroom breaks. Because a lot of kids will say, I don't drink water at school because we're not allowed to use the bathroom at certain times during the day. And they don't want to have to use the bathroom and not be able to. So even just writing a letter that says unlimited bathroom breaks throughout the day so that they'll be encouraged to drink water makes a huge difference. So I include all of this to kind of accommodate them and help improve that quality of life, because if they're able to put some of those simple lifestyle modifications in place and reduce their headaches without medicines, or reduce the need for medicines, that can be impactful.
Got it. Okay. Migraines appear everywhere. And it seems like when you turn on the TV, at some point in time, you'll see an advertisement, whether it's from like Lady Gaga or Serena Williams. I actually don't know if she has headaches or not, but or migraines. Why do you think it's such a commonly like claimed headache? Or is it just that prevalent?
That's a great question. I think both. I think there's a misconception about what migraine is, and people tend to just think that migraine is a bad headache. So a bad headache or severe headache is migraine, and then a milder headache is just a tension headache is the common misconception. But migraine, now what we know about migraine, it's a brain disease. It's considered a neurologic disease, and it's a disease state. And so we think of someone with migraine, they have migraine even without active symptoms. And that's similar to someone with epilepsy. Even if they're not actively seizing in front of you, they still have epilepsy. They have the propensity to have seizures. And so it's the same with patients who have migraine. And so understanding it from that standpoint and kind of trying to treat the underlying cause, we know it's genetic. Almost 90% of kids with migraine have a parent with migraine, and that parent has a parent with migraine, and that parent.
Oh, wow.
And so there's a big genetic basis for it. So it is a lot more than just a bad headache. It can impact every sense, your ability to see, light sensitivity, sound sensitivity, smells, impact how you taste. It can just cause you to have people with migraine sometimes can't wear their glasses or their hats or their headbands when they're having symptoms because their scalp is sensitive. So it really impacts all of the senses.
It's interesting. Are there other headaches you feel like are maybe miscategorized by maybe other like us, like colleagues in the medical field, or just by the general public?
Probably. Another common misnomer I hear sometimes is cluster migraine. It's like a combination of cluster headaches and migraine. And what I think people mean when they say that is just that it's usually behind the eye or unilateral, but usually that's just associated with migraine and is separate from cluster headaches. That's one misnomer I see sometimes.
Got it. Okay. And you mentioned earlier the definition of a migraine being a brain disease now. Do we know much more about the pathophysiology or the etiology outside of it being kind of a hereditary component?
We do. We know a lot more in the past, I would say 8 to 10 years than we've known before, which is where all those medicines come into play. Like you mentioned, the Lady Gaga, the Serena Williams, the other one is Khloe Kardashian, because the kids will come in and tell me like the commercials they've seen and who's on them. So I've had to learn. But those medicines, they're targeting a molecule called CGRP, calcitonin gene-related peptide. And so there are several now classes of medications that target that area, because what we've learned is it's one of the main drivers in migraine. We know that those levels are elevated during an acute attack, and you can induce an attack by elevating CGRP. Wow. And we also know that at baseline, people with chronic migraine have higher levels of CGRP going around than people who do not have migraine. And so by targeting that with monoclonal antibody therapies, which are monthly injections that you've seen on TV, and there's also some pill forms that antagonize CGRP, we can get more targeted treatment, less side effects. In the past, most of the meds we used for migraine were seizure meds that help work for migraine, or antidepressants that help work for migraine, which makes sense because they're all trying to attack similar neurotransmitters. But these medications are the first class of migraine designed migraine-specific meds, which make it a very interesting time to be in the field.
Yeah, I'm sure it's kind of nice to have another sort of tool use? Is there a common medication you use initially for most patients with migraine?
For children, we usually are starting still with the basics. We use supplements a lot from the beginning, depending on the frequency. So we use magnesium, we use riboflavin, sometimes we use melatonin. There's also coenzyme Q10 that we'll use. Those are some of the more common ones.
Interesting, okay.
And then medicine-wise, we go into topiramate and amitriptyline. Those are the most studied in pediatric migraine. Beyond that, though we have these wonderful new treatments, none of them are FDA approved for kids yet.
Really?
Yes.
Okay.
So when we do use them, it's off-label, and I do use them in kids all the time if they have not responded to 2 or more of the traditional therapies.
Are you getting pretty good success, you'd say? With
Wonderful success with them, yes. I'm hoping that eventually it will become more widespread.
Yeah.
We're doing a clinical trial here with one of them, Remigipant, which is Nurtec, to try to help that process of getting these meds available for kids.
Are there predispositions that some kids have to migraines that I suppose they'd be hereditary or maybe not hereditary?
In general, they're mostly hereditary. Some other common things or comorbidities we see in these kids will be other pain disorders. So a lot of them may have fibromyalgia or other, we call amplified musculoskeletal pain. I see a lot of those kids in conjunction with our pain clinic. So we see that comorbidity often. We see anxiety, we see depression. Interestingly, we've learned that with adequately treating the migraine component of things, the mood symptoms improve simultaneously. Wow. It used to be thought of that if you don't improve your depression or anxiety, your migraine won't get better. But it's really, if you don't improve the migraine, those things often don't get better. It's
chicken or egg sort of thing. But it sounds like we found which one's first in this case. Wow.
Yes. So that's been interesting. But those things often come together as well.
What other, do you separate those in abortive versus preventative medications?
Yes, that's a big point of education that I do with families, is knowing the purpose of the preventive medications, giving them a good understanding of how they're going to work. So it can be painful with the preventives because usually you need to be taking them for at least 2 to 3 months before you see any results. And it's hard to just be taking something for that long, waiting for it to work, and then before you escalate dosing. And then I explained to them how to use their rescue medications. For the case of migraine, they're usually going to get an anti-inflammatory med and a triptan med. And we'll rotate through those to find the one that's most effective for them. I'll often counsel about making sure they're not overusing those because we know that medication overuse can make your headaches more chronic over time. So we do a lot of education there right from the beginning.
Could you talk a little bit more about that medication overuse headache that you see?
Very common. So we know that with using even over-the-counter, actually especially over-the-counter medications like Excedrin migraine, it can be naproxen, it could be acetaminophen, that if you're using those regularly more than 2 or 3 days per week for more than a few weeks at a time, you are at risk from going from episodic, which is just episodes of headaches that may be less than 15 days in a month, to more chronic and then continuous headaches over time if you're continuing with that frequent use.
How readily accepted is that information by patients and by parents?
It's frustrating because they're taking it because they need something to relieve their pain. And so it's hard to say, okay, I know you're having headaches every day. Yeah. You can only use your rescue medications 3 days per week. It can be very frustrating. But what I usually like to do is give them a plan of what they can do on those other days. There's also neuromodulation devices that we use for migraine. So there's physical devices that you can put either on your head, on your arm. There's different ones that either give they're like a TENS unit or electrical stimulation to some of the nerves to cut down on pain. So we'll do some combination of medication and neuromodulation devices as needed.
Interesting. And we're not talking about implantable devices?
Right. They're external. That's a good question. Yeah. So one is called Cephaly. It's one you wear on your head. The devices all have like a dual function. So you can use them daily as like a preventive, and you can use them as needed for rescue. And you can't overuse those.
Yeah.
So that's nice. So Cephaly's one. Another newer one's called Neurivio. It's remote electrical stimulation. So it's on the arm. It gives electrical stimulation to some of the descending nerve fibers that we found connect back and give feedback back into the brain. I know. This is very interesting, but the data on it is wonderful.
Really?
Teenagers love it because they can take it in their locker.
They're probably
bring it
proud
out.
of it in a way.
They like it.
Yeah, I was like, got this.
They
cool
do.
Device.
I think it gives them a sense of control over what things they can do, and they don't have to go to the nurse and ask for medicine and all this too. So I try to encourage them. There's external VNS that you can use. It's called GammaCore that you can use as needed. So there's other non-medicine options we can do in between.
That GammaCore, is it just pinch under your ear? Where do you put it?
This one goes in your neck.
Okay.
It has like two prongs. Yes.
Yeah.
Yes. There are ones that go in your ear.
How do you put it? Is it just sticks there?
You
It's like
hold it there for just a minute or two.
All right.
Yeah.
Got it.
Yeah.
Where does Botox, botulinum toxin, fit into the treatment algorithm for migraines or for headaches in general?
It's FDA approved for chronic migraine, so 15 or more headache days per month, 8 of which are consistent with migraine. It's only approved in adults, but it's one of those, again, it's been around for so long, you can usually get it approved off-label in kids if they've tried X amount of traditional medications for their migraine symptoms. And it's a nice option because it's not interacting with other systemic medications that they may be taking. It's something that they come in, they can get done. It's 31 injections. So initially up front, that sounds very intimidating. But once they do it the first time, it's like, okay, I was worried about doing Botox in kids because I didn't know how they would react.
Yeah.
I found it's just as easy, if not easier, to do it in a child than an adult. Yeah, they handle it really well. Wow. They handle it really well. And then it's done every 12 weeks. Okay. So they get a break in between.
I'm sure parents have questions about how that affects their musculature as a kid growing up. What do you tell them about like the adverse side effects or potential risks?
Yeah, it's honestly, it's a very low risk. You can use it chronically for an extended amount of years. A lot of people do. They'll start off with it in adolescence and they'll be using it into adulthood with no issues. It wears off over time, so that's why you have to keep coming back to get it. And usually if you don't have side effects with the first 1 or 2, you typically don't have them.
And we typically in the PM&R field where we treat spasticity, we usually use that rule of 3s where it's like it takes about 3 days to start on for the onset and 3 weeks to see like peak effect and it lasts for like 3 months. Is that kind of the same philosophy with pediatrics? Yes.
And then on top of that, with migraine, we expect it to really have maximal impact after the second or third round. Okay. And then from there, whatever you're getting after round 2 or 3, we say you're just going to sustain from there. And if you're not getting benefit at that time, we usually will stop.
Got it. Okay. What are some of the don't miss diagnoses? And I think you mentioned them kind of when we first started talking about, I think parents probably come in with questions like, does my kid have a brain tumor? That's the way they keep getting these headaches. Does my kid have a brain tumor? And then how do you work up those things when you have a suspicion? Does it just, you immediately go to imaging or?
So for younger kids, especially when you're not sure and they can't tell you so much, 6 and under is usually our cutoff. If you're coming in with headaches, even if they seem infrequent, we're usually getting imaging. Okay. Because in that age too, you start to worry about posterior fossa tumors. They're pretty common and present in that age as well. But I have seen migraine present at age 3, 4 with normal neuroimaging and a strong family history, and we start treating. But in a young kid, you're going to get imaging to rule that out. Yeah. Another big thing you're going to look at when they come into the office is the optic nerves. So you're going to do a fundoscopic exam and make sure you don't see any optic nerve edema or papilledema. And if we see that, we start to get concerned about increased intracranial pressure. There's a condition called IIH. We call it idiopathic intracranial hypertension. And so when we see papilledema, we think of that amongst other reasons why pressure could be elevated. So we get imaging, but then we also, if that's not showing anything, we'll do a lumbar puncture and check the opening pressure. And that's how we can diagnose that condition.
Okay. How much of your physical exam, and I know the fundoscopic exam probably is part of that, but how much of your physical exam helps or aids into the diagnoses?
All of it does. If someone's coming in with episodes with their headaches and they're coming in, they'll have sometimes a lot of neurologic symptoms during it, like double vision, numbness. Sometimes they'll feel weak all over. And then that goes away in between. A lot of what I'm looking for in my exam is to make sure there's no residual weakness, that you're having good muscle tone, that there's no sensory deficits, good reflexes, coordination, and all of that. If I see anything abnormal, especially if it looks more focal, I get worried there's something secondary going on, and I'll do imaging.
Got it. Okay. What considerations would you like other specialties or parents or even your pediatric population to consider in treating headaches?
I think a big one, a big takeaway that I've gotten really from families is just, especially with kids, but it's probably true for adults, is they sometimes feel like it's their fault that they're dealing with their symptoms, because sometimes we're telling them things that are true, like you got to drink water, you got to do this. And sometimes it can come off like we're saying, you did this to yourself because you didn't do X, Y, Z. If you fix this, you'll get better. And if you don't, that's on you, kind of thing. And I think if we can explain it more from the brain disease aspect of it, it kind of takes some of that feeling of blame away from them and makes them more open to the other treatments and lifestyle modifications that you're going to want to implement.
Gotcha.
Yeah.
Are there any stories or testimonials that you can share with us about patients you've seen that been pretty surprising to you?
I have a lot of them. But I've gotten the privilege of seeing some kids I started seeing as a resident when they were much younger through their college years up through 21. And we do some work with an organization called Miles for Migraine, which is a patient advocacy and education organization. And they do races throughout the year. We did one recently in Atlanta. And I asked one of my patients to come speak as the patient advocate. And she was able to come do that. And kind of just watching her, how she evolved from like a little girl with migraine who didn't really have much understanding of what it was or how to treat it, and who still is really a chronic migraine sufferer, but who was able to, in front of an audience of hundreds of people, advocate for teenagers with migraine. I think was awesome to be able to see how she evolved through not just being someone with the disease of migraine, but someone who could advocate for others. And I have lots of other teenagers like her who are now advocates in the field. Yeah.
Awesome. Well, Dr. Forte, thank you so much for your time. Really appreciate it. And it's great talking to you.
You too. Thanks for having me.